Good afternoon, everyone. One of the comorbidities that clearly requires thoughts around integration is that of tuberculosis co-infection. And so it's my pleasure this afternoon to really talk about some of the challenges of service integration and focusing on the TB model. I'm building on some fantastic talks that were given on whatever day it was, probably Sunday, at the Stop TB program, focusing on Southeast Asia. And it's clear they've made some fantastic progress in that region of the world in this regard. And then, of course, Diane Havler's talk this morning was beautiful, and so I will build on that. There is no doubt there is a great deal of tuberculosis in the world, and consequently a large amount of HIV co-infection, 13% of TB, 8.6 million new cases of TB is co-infected with HIV, and that results in a great deal of death, as Diane showed so beautifully this morning. Again, these graphs and maps, we're very familiar with. These are the TB incidence rates, and it's clear that in parts of the world where you see that deep red color, the force of infection of tuberculosis is enormous, and really what we describe as a generalized tuberculosis epidemic. We have on top of that, of course, the HIV prevalence tracking very much in similar regions. And so it's no surprise that co-infection is very high, particularly in those regions in southern Africa. And so, as we've seen over the last few years, as the percentage of people who receive antiretrovirals has increased, there's also in the background an increasing number of people receiving TB treatment. So the two overlap, and perhaps you could say it's a no-brainer that we really have to think about how we integrate the two. And the way I think about this, I come from Cape Town. HIV is occurring in a sea of tuberculosis, and TB is occurring in a sea of HIV. So in our TB clinics on the ground, the reason TB becomes a very common reason for having an HIV test done and acquiring a new diagnosis of HIV. We know the symptoms can often run together, so people present at clinics sort of feeling unwell, and it could either be TB or HIV that is driven there, or indeed a co-infective sort of scenario. And then, of course, now in our new setting with our new recommendations, this becomes an indication for referral for antiretrovirals immediately. In our HIV clinics, on the other hand, TB is not always symptomatic, but we are highly recommended, and obviously I just want to make this plug again, we always need to actively case find for tuberculosis. Particularly in the setting of advanced HIV, people may not have the typical symptoms of tuberculosis, yet we know that they may well be harboring TB disease, and it needs to be looked for. Again, this is an indication to start antiretrovirals regardless of CD4. In our primary healthcare clinics, where people come just because they're not feeling well, I've already mentioned both conditions often present simultaneously. So I'm afraid I come from one of the capitals of tuberculosis in the world. We annually notify about 32,000 cases from one city, and you can see we outstrip, the darker blue is North America, and there you see the United Kingdom. So we really do notify a great deal of TB. And the TB HIV component, this part that is red in the graph, is that young adult group that is particularly burdened and come to our services, have a high risk of being lost if services are fragmented, they don't get the service they need, and it's clear that this needs to be addressed within our health systems. When we look at people who are actually initiating antiretrovirals, and this is our clinic, a large clinic of 10,000 people in Cape Town, you can see the burden of TB within the antiretroviral service is enormous. Total TB burden, almost 70%, a past history of TB, almost 50%, on TB treatment at the moment, about a quarter, and those who have a TB diagnosis because they've come for antiretrovirals, again, about a tenth. And we know this doesn't this isn't a surprise. We know that as people's CD4s erode and they become more advanced, it's more likely that they're going to get tuberculosis. The good news is, the flip side, if we can get them onto antiretrovirals and actually enhance their CD4s, we know that the incidence of TB is reduced. So that's the goal. And this is Steve Lawn's beautiful work where he's shown very clearly that if we can keep people's CD4 counts up, the risk of them having new TB is much reduced. So the presentation of TB and HIV can either be that TB is diagnosed before starting antiretrovirals. It can develop in a patient whilst on antiretrovirals. And we know particularly that first 4 months when, if you like, you flush out the tuberculosis. And we need to be very aware. If we don't screen very effectively before we start antiretrovirals, you can bet that in my settings and in many settings around the world, you will see tuberculosis in those first few months. A patient may also have defaulted ART, develop TB, and then come back into our services because of that. So why the reason for urgency? Well, we know patients to be HIV positive who develop TB and are not diagnosed or treated have a very high rate of morbidity and mortality. Diane showed beautifully this morning, this is the killer. It's the killer in Africa, it's the killer in many parts of the world. In addition, of course, although a reduced risk, they are an infectious risk to others. And often HIV tracks together in households, and so we actually see sort of minor pandemics or clusters or outbreaks happening within households when TB is brought home. Patients known to have TB who are diagnosed HIV positive need antiretrovirals, and as you heard again this morning, recommended that is within 8 weeks if at all possible. Delays, as I say, result in morbidity and mortality. There's a number of randomized controlled trials. You heard about them this morning, Camellia, Stride, etc., particularly when a CD4 count is low. A little bit of controversy at the moment in the higher CD4s, and I guess we're going to need to watch that space as to what WHO will do with its recommendation. But at the moment, it's kind of within 2 to 8 weeks to get people onto antiretrovirals. So I just want to look at a little bit of data from Cape Town from 2009 to 2011. You can see a large number of people, almost 80,000 TB cases in that time, with about a 50% co-infection from the city. And they're just bringing it home that if you start ART, you save lives. If you don't get ART on the go, people die, and they die early. So half of the deaths in patients who did not start occurred within 8 weeks. So again, bringing this home, we really do need to move. However, even in a city where the health systems are pretty good, and we actually are, you saw there, we're almost testing everybody that comes into our TB clinics for HIV. We're doing really well in that regard. We aren't necessarily scoring on the integration and rapidity of getting people onto antiretrovirals. So 82% of our population have CD4s under 350. 91% of deaths in HIV positive patients occur with a CD4 that is low, and 32% of patients with CD4s less than 350 did not start ART in this period. That's 1/3. That is bad. And, I will echo again what Diane said. This is a public health failure, and we really, really need to look at this as practitioners around the world. Mortality for patients on ART was 50% less than patients not on ART for CD4 counts less than 350. And the median time to death, I already mentioned, was less than 8 weeks. So delays occur when patients have to move between facilities. A median delay of 16 weeks, 4 months between the start of TB, when TB was diagnosed there and they had to get to our clinic in Guguletu. When we actually made the diagnosis in our clinic, it was reduced to 41 days, which is a huge improvement, but still perhaps not good enough. But there you can see already, if you can do it in the same facility, you can make a big difference. Median delays of 2.66 months between the start of TB treatment and the start of ART in 3 of probably the most organized clinics in Cape Town, one down in the south in Gugs, and the clinics run in Khayelitsha. So let me just spell it out again. When you have TB clinic where HIV testing is being done, and that's a triumph, and it's one of the 3 I's, and we need to do it, and you generally, in the old system, needed to refer for antiretrovirals somewhere else, because these were siloed systems. Or at the HIV ART clinic, somebody was diagnosed with tuberculosis. Again, there was referral to other clinics to get TB treatment. This results in missed opportunities for HIV testing, for active case finding, for instituting IPT, for instituting cotrimoxazole, and it results in inherent delays and loss to follow-up. Again, for the patient, if I have HIV, I'm referred for antiretrovirals, I start my ART for life, I have a system of adherence. In different places in the world do different systems. They may have adherence counselors. They go down a system of needing their treatment on that side. If I have tuberculosis, I probably go into some DOT support system for the next 6 months. I get my care there. If we don't integrate our care in some form, this poor individual is spending all their time looking for their treatment. They're either going down here to get sorted out for antiretrovirals, and for 6 months they're trying to get their TB treatment. And I'm not surprised that in many cases our patients just kind of, vote with their feet and stop coming altogether. And this is the worst case scenario. So it wastes time on the part of the patient and of the health facility staff. Clinics become overburdened, and more importantly, patients become overburdened. And so as part of this, the Stop TB system has spoken about integrating services. And so integration becomes the 4th I. I heard about a 5th I, which was immediate treatment on Saturday, which I thought was quite interesting. But tackling the 3 I's are, in this kind of model, we can talk about intensified case finding, INH prophylaxis, infection control. But there are other advantages in TB suspects and patients. For example, you can test all for HIV, offer ART without delays, the 5th I, and streamline services to provide both medications hassle-free, okay? I work with adolescents. The term hassle-free is very, very important. People need to be able to access their services easily. So what are the models? The models are co-locate the services in the same clinic with referral between services. So you bring the TB clinic together with the antiretroviral clinic. My only concern with that is I have found a loss to follow up in a separation of 50 meters. I don't know how that happens, but patients can get lost walking from one side of the clinic to the other side of the clinic. Co-location of services with shared management discussions and shared adherence support services. So you might still have the TB nurse, the ARV nurse, but they come together and talk about the patients, and at least the adherence support is one kind of support. So that's one model we've used, and I think we've used effectively. Integration of services completely with HIV antiretroviral services managing their own TB. Very nice. Integration of services that started out as TB and now start to distribute antiretrovirals. Again, very nice. Or where, if you're starting a clinic, and I'm saying this to health managers and policymakers, that is going to supply HIV, do not do that without also making sure they can do TB. And or you're going to start a TB clinic, don't do it where you aren't also adding HIV. Let's do it from the beginning, because then the staff know what they have to do. So that's a recommendation. So this is the model I just described, where and it's kind of a transition model where you're saying to people, let's come together and do this together. It requires health management change, and that's always hard. So if you can sort of do this intermediate model where still the TB services are there, the ARV services are here, but they share some of their support, etc., it's very useful. So I just want to show you some data, how this can help. After we instituted that model I've just shown you in one clinic, we saw that the DOTS burden at the clinic reduced. So patients did not have to come every day to pick up their pills for their TB. We said, right, there are already antiretroviral counselors out in the field. They will make sure that the patient swallowed their first 2 months of their doses in tuberculosis. And that worked very well. And then after that, they just kind of got into the adherence support system. The nurses loved this because suddenly they saw their DOT support burden in the early morning, that big rush when they're all coming in to pick up their pills, reduced markedly. So again, it becomes an incentive for staff. So I looked at the literature to say, well, what's happening around the world? This was a nice systematic review done by Alison Grant and others in 2010. She looked at 136 papers describing models of integration. None of them were randomized controlled trials. Very few had outcomes, and here's a gap for us. Models based on referral only were easiest to implement. In other words, that's kind of status quo. The referrals, of course, often failed. Communication was very important and actually often was inadequate. And that's really the scenario, the fragmented healthcare system where we see this thing failing. More integration, she noted, needs more staff buy-in. And this is really important. Don't think you can just do this in your clinics, walk away and think it's gonna work. Staff really need to invest in this, and it requires training. So going into this a little bit more, what were some of the barriers? Well, service users were unconvinced of the need for more testing. So when you said to them, you've got tuberculosis, but you know what, now we need to test you for HIV, they were like, really? And I have to go somewhere else for it? Not on your Nelly, I'll take these pills, but that's all I'm going to do. Those who were referred battled to find referral services. Poor communication between services was important. Supply of drugs and test kits were unreliable. Staff were not motivated to take more. Joint staff training and support was a plus, and identifying a staff champion was a plus. So I'm going to just make this point that integration of service, though, doesn't always mean that the thing comes together. And here's just one case where in Cape Town, where we looked at 13 integrated and 4 single service facilities, 13,000 people, and you can see that actually outcomes were very similar. So it doesn't necessarily mean that just because you integrate services, things are going to get better. You also need to address how people manage cases and how things go forward. So my conclusions are, there is a burden of co-infection, especially in areas where TB and HIV are hyperendemic. Both diseases require long-term adherence to medications. Outcomes are improved when TB-HIV is managed actively. Delays in treatment leads to increased morbidity and mortality. It's pragmatic to co-locate and move towards integration, paying attention to infection control as you go. And more research is required that measures outcomes so we can be sure that we actually are doing what we need to do. So thank you very much.